So, without further ado, okay, Dr. Hinjimli, you can start your presentation.
Hello, hi everyone. I'm very happy to be here today and to kick off this initiative of the World Psychiatry Journal Club. I want to thank Dr. Wennes for giving me the opportunity to be the first presenter, and also thank Professor Cohen for being with us today. And I'm going to start directly with a short introduction. So, the management of people living with major depressive disorder is a therapeutic challenge, as we know. Patients failing two adequate antidepressant trials are typically classified as treatment-resistant depression, and contribute disproportionately to healthcare and unemployment costs. Anhedonia is a core system that is often overlooked in treatment-resistant depression. And from this came the idea of using dopamine agonists such as Pramipexole for their potential antidepressant effects, which has been supported by several small controlled trials and observational studies. So the aim of the study was to assess the efficacy and tolerability of pramipexole augmentation of ongoing antidepressant treatment over for 84 weeks in patients with treatment-resistant depression. Moving on to methods. So this was a multi-center, double-blind, parallel group, placebo-controlled randomized trial that was conducted across 9 sites in the UK. And recruitments took place either through referrals from primary and secondary care services or online and poster advertisement. And I think we're going to start with our two first questions here for the audience. So, randomized controlled trials in general can be classified according to several design features. What are the main comparative structures that you know that are used in RCTs? So here we have parallel group design. What other comparative structures are you familiar with?
So, just for participants, you would like to have this. The idea is to have a journal club that's as interactive as possible. So, yeah, I think your participation is very important, not just as receivers, but we want you to be active actors as well. So, the question was about, so there are different types of RCTs. Uh, this RCT in particular is a parallel group one. Do you know of any other designs for like comparisons or not? So you can actually switch your camera on and your mic on and directly try to answer. Okay, otherwise we will, we can discuss this together, Dr. Hind. So what are the types of like the other types? So parallel group, if I understood correctly, means, I mean, it's very clear. So we have, for example, here placebo versus pramipexole. So like people who are randomized to one arm will not get the other, like the other uh, treatment or okay. So two interventions in parallel that we just need to compare. What are the other designs that are possible?
So we could have a crossover design, what we call crossover, and participants actually receive both interventions, but not simultaneously, that is sequentially. So, for example, a group would get a treatment, and another group would get another treatment, and then they would switch over with a washout period in between. Is that correct, Dr. Winnes?
Yes, absolutely. So that's yeah, a crossover design. That's also quite commonly used, but the most commonly used design is actually a parallel group design. Okay.
Okay.
So you said you had two questions.
Yes. So the second question actually concerns the word placebo. This RCT is placebo controlled. So what types of control conditions can be used in an RCT other than placebo?
Okay,
Could you
so
please?
there are also here, I think we need to distinguish between pharmacological RCTs and psychotherapy RCTs, in particular in psychiatry. So in pharmacology, usually we use placebo and or an active comparator. So sometimes you use a medication that's already known and used in this indication. Okay, that's a possible comparator, active comparator. And this is, I think these are the most commonly used controls, but also we can use a treatment as usual. So we can compare, especially naturalistic studies versus treatment as usual. We can also have, especially in psychotherapy, so we can have a fake psychotherapy or a sham psychotherapy thing, but you can also have a waiting list. So the waiting list control is not the best control we can have, so it has its limitations. And even now in like meta-analysis, etc., you will always see statistics done, including studies that had control lists or waiting lists as controls, and excluding these studies as well, because these are not like this is not these are studies with not so good, let's say, controls, the waiting lists. Okay. Did I miss anything?
No, I agree. Thank you.
Okay.
Okay, now eligible participants were adults aged 18 years old or older. All participants met the DSM-5 diagnostic criteria for major depressive disorder, and they scored 10 or higher on the quick inventory of depressive symptomatology self-reported version, and this is going to be our primary outcome for this RCT. And the present depressive episode was characterized as treatment-resistant depression. And treatment-resistant depression was defined in this study as lack of therapeutic response to an adequate course of at least two licensed pharmacological antidepressant treatments, so two types of antidepressant treatments, defined as at least 4 weeks of treatment, unless limited by tolerability, at the minimum dose recommended. And I want to draw our audience's attention to this definition because we are going to come back to it later. So exclusion criteria were quite comprehensive, and just to name a few, current diagnosis or history of psychosis, bipolar disorder, or Parkinson's disease, current or previous clinically significant impulse control difficulties, and this has to do with the side effects of pramipexole, serious suicide or homicide risk, and concomitant antipsychotic drug treatment. So a centralized randomization system to determine which participants will be assigned to the placebo or pramipexole group was implemented within a non-deterministic minimization algorithm to balance important prognostic factors such as trial site, age group, self-reported sex, and baseline depression severity. And here we have another question for our audience, one that is maybe a little bit more difficult, which is what do we mean by minimization as a method of randomization? I have personally learned a lot about this paper, and this was one of the highlights for me, one of the things that really was quite beneficial. So if anyone could maybe attempt a definition, even if it's not perfect.
And you'll see that many of these notions are very important in most recent RCTs. So hopefully when we hold like future meetings, you will see that there are so many things that we discussed today and that you will also find in other articles, especially in randomized controlled trials. So these are methods that are commonly used to attenuate some kinds of bias. And so what kind of bias can be attenuated by minimization algorithm? What's the problem you think, Dr. Hand, that this minimization algorithm tackles?
Okay, so I did a little bit of research to understand this notion. And simply put, what I understood was um, it's important to balance the two groups uh, so that um, so that we could understand the the results basically. And
Absolutely. Mhm.
and minimization is a way of randomizing so that we have kind of a balanced treatment groups by taking into consideration these variables. So, for example, when we take into consideration the age group, we would make sure that we have similar age groups between the placebo group and the pramipexole group. So we don't, for example, end up with a group of placebo group with an age of 50 or more, solely composed of 50 or more, and maybe a young group for in the one that is getting pramipexole. So this is basically what I understood.
Yeah, exactly. So what can really ruin an RCT is the non if the groups are not comparable. So a perfect RCT should have perfectly comparable groups. So the placebo group and the active group should be exactly identical, I mean, in theory. Uh, except for one factor, and the factor is the intervention that we are testing. Otherwise, the groups should be completely comparable. Of course, in reality, when we randomize, when you have a simple randomization, you never know, especially with not so large sample sizes, you might end up with having, for example, the placebo group having less severe depression or a higher age or other factors that can influence the outcome. So this is why one of the methods and one actually of the newer methods to tackle this problem is the use of a minimization algorithm. There are other possibilities to tackle this problem, but probably the minimization algorithm is one of the best, if not the best method to do that. The problem with minimization algorithm is that it makes the sometimes the masking a little bit problematic because maybe the clinicians can maybe predict who's next on the list. So they might predict if the next participant would be, for example, thanks to this algorithm, assigned to placebo or to the active treatment. And this is why they needed the non-deterministic part. So there needs to be some random part in that allocation as well, right?
Absolutely, yes. So the non-deterministic part means that uh, kind of chance still plays a role. So um,
Mm-hmm.
so that the groups are balanced, but the allocation is not fully predictable.
Mm-hmm.
And in the case of this study, what happened was the first 10 participants were allocated completely randomly, and then the minimization was applied with an 80% probability of choosing the allocation that best reduced imbalance.
Yes, absolutely. And also they made sure that the randomization was centralized, and this is very important because if it's centralized, they had multiple sites, and it's much more difficult for like clinicians or to predict the allocation of the of each or the assignment of each participant because they don't really know what's going on in other sites usually. So yeah.
Yes, yes, thank you. And then finally, participants were assigned with a ratio of 1 to 1 to pramipexole or placebo. Participants, investigators, researchers, and trial statisticians were blinded to treatment allocation. And here I actually had a question. Could we say that this is actually a triple blinded RCT because the statisticians as well were were masked to the allocation? Is this a definition of triple blinded?
In fact, I'm not sure if this term is commonly used. I think because we are inherited terms from past, RCTs, and at that time, they started with non-unblinded, then single blind, and then double blinded. But currently, the state of the art RCTs, I mean, they need to blind everyone I mean, statisticians as well, because you know that the results also depend on on the statistical model we use. So everyone, I mean, data analysts, researchers, clinicians, even if there are clinicians that are not directly involved in the research but can see the patient or the participant in this case, they all need to be blinded for because I mean every time we have someone who's unblinded, this can create some kind of bias, either expectancy bias for the patient, analysis bias for the statistician, sometimes intervention bias for investigators, and so on and so forth. I don't know if Professor Cohen maybe can also give us. I mean, do we commonly say now that a trial is triple blinded or quadruple blinded or something like?
Yes, Sammy, it isn't a term I've come across much, and I think it's as you suggest that the concept of double blind has gradually broadened to include as many people as possible.
Absolutely.
Okay.
Okay, thank you.
Thank you. Okay, so unmasking, however, so functional unmasking was conducted during this study, and again, this was one of the th terms that was a bit new to me, and I did a bit of research to understand what it means, and I want to ask our participants again if they have heard this term before or what functional unmasking could mean.
This is a very important concept nowadays in psychiatry, especially with the newer interventions such as psychedelics or TMS, or, so we're increasingly talking about functional unmasking. Some people also call it functional unblinding. I'm not sure if there's any real difference between the two terms. My understanding is that currently both terms are used interchangeably. So I don't know if anyone has any idea about what's functional unmasking. This is a very crucial concept in today's psychiatry.
Good evening.
Good evening.
Hi, good
Hi.
evening. Hi, I'm Dr. Kapili from Philippines. So I believe functional unmasking occurs when participants or the clinicians or even the assessors correctly infer treatment allocation due to the noticeable effects or side effects of an intervention, despite the formal blinding procedures being in place.
Absolutely. So that's exactly the correct definition. Thank you, Dr. Capilli. So exactly. So sometimes, despite the formal blinding, sometimes patients or clinicians can tell if the patient was allocated to the active arm or to the placebo arm. And this is usually due to immediate effects that we can see. So if the drug has, for example, very clear and immediate side effects, such as dissociation, hallucinations. In this case, for example, for pramipexole, we can have problems such as sometimes psychotic symptoms in some cases. So if you have very prominent side effects or effects that occur immediately, especially, patients can tell, and also investigators can tell if the patient received or the participant received drug A or a placebo or drug B. So this is mainly a problem now because, with psychedelics, we all know that many people would be able to know if they received the psychedelic versus placebo, or if they used, for example, any drug with any immediate action or possibility of action or side effect versus placebo. So this is very important, and this is a problem that needs to be addressed because if there's functional unmasking, we can have an expectancy bias. People who know that they received the medication, the active medication that is, might expect to get better, and then they might actually get better because of this expectancy bias.
Yes, thank you. Thank you, Sammy. So, as we said, functional unmasking was conducted during the study after all study treatments, so around the 48 weeks mark. So researchers asked participants to guess whether they had been receiving pramipexole or placebo and to rate their certainty for this guess on a scale of 0 to 4. So here are the outcomes that have been used in this study. As we said, the primary outcome was the kids SR16 that measures the severity of depression, self-reported. Secondary outcomes could be divided into either efficacy or safety outcomes. So we had the kids C, so that is kind of the clinically rated version of the primary outcome. So SHAPS that assesses anhedonia, and we had the GAT scale for the severity of anxiety, WSAs for functional impairment, TSQM to assess treatment acceptability and satisfaction. We also had QUIP RS to detect impulse control symptoms, ASRM for the symptoms of mania, and the item 12, I believe, of the KID SR16 was used to assess suicidal ideation. Now, moving on to procedure. So there was a screening and run-in phase during which patients went to a 2-week run-in phase to kind of to make sure that the measurements were stable and to run through eligibility criteria again, followed by eligibility and randomization that we talked about. Study medication, so the Pramipexole version that was used was immediate release, and it was a nightly, so patients took the treatment once a day at night. The starting dose was 0.25 milligram, and it was increased every 3 days throughout the study, and the target dose was 2.5 milligram by week 4. Analysis was conducted using the intention to treat population. We'll get to that later. And after week 12, antidepressant adjustments were allowed. And we will also detail this later. And the placebo followed the exact same titration schedule. The doses could be reduced to the maximum tolerated level if adverse effects occurred. Outcome measures were collected weekly until week 12 and then every 4 weeks until week 84, as we said in the intention to treat population of all eligible randomly assigned participants. And the sample size calculation assumed that 3-point difference on the kids SR16 was considered as clinically significant. The effect size was 0.56 and for 90% power and an alpha of 0.05. So the sample size that was initially predicted was 136, but then the actual dropout rate was actually 8%, and with additional mechanistic outcomes that were actually in another paper, they required dropping the alpha to 0.025, and the final sample size was 187, which means 98 participants per group. Treatment effects for continuous outcomes are reported as adjusted mean differences for binary outcomes such as response rate or remission rate, as relative risks, and for count outcomes such as number of adverse reaction as incident ratios, all with associated 59% confidence intervals. Absolute values of continuous outcomes are reported as mean, binary data as absolute numbers, and count data as median. Intercultural ranges. The primary outcome was analyzed using a generalized linear mixed effect model. And here I would like to take a bit of time to explain what mixed effects model means. So actually This model was applied to all KID SR16 data that was collected up to week 84. Fixed effects were used because these variables influence all participants in a systematic way. So the model estimates their average impact across the entire sample and adjusts for baseline differences between groups. So this helps that any observed treatment effect is not explained by underlying differences. Here, it was the treatment group, so placebo or pramipexole, time point, so the week of follow-up, accounting for repeated measurements, the time treatment group interaction. So simply put, does the rate of improvement over time differs between the two groups, and minimization variables that we mentioned earlier. So the trial site is considered a random effect, which means that different sites may have slightly different outcomes for reasons unrelated to pramipexole. So the model adjusts for this to avoid being biased by these differences. And random intercept accounted for the natural heterogeneity in starting depression scores, because of course patients did not start with the same score. Was my uh, definition correct, Dr. Reines? Do you have something
Yes,
to add?
absolutely. I think it was very good, very clear. And I think, okay, once we also tackle more RCTs, we are going to see more of these uh, like GLMs, generalized linear mixed effects models. So it's a very common way currently to assess the main outcome of the RCT.
So there are other details, of course, to the methods, but we just stick to maybe the most important ones. As Dr. Wannes said, this is our first journal club, and it was important to start with the fundamentals. Now, moving on to results. So a total of 270 participants attended a screening visit, of whom 66 were included either for ineligibility during the screening visit or during the running phase. And with the remaining 151 participants being randomly assigned to either pramipexole or placebo. The primary outcome data at 12 weeks were collected from 86 pramipexole treated and 76 placebo treated participants. 40 pramipexole treated and 93 placebo treated participants reached the 84-week follow-up. In many patients, the depressive illness was chronic, with the median duration of the current episode of the overall cohort was 8.5 years, and the interquartal interval, the EQR was between 4 and 16, sorry. There was a substantial degree of treatment resistance to conventional antidepressants, with an average of 3 to 4 antidepressants that were not deemed beneficial for this episode. Scores on the KIDS SR16, so our primary outcome, indicated a mean level of depression in the severe range, so overall 16.3. While ratings on the WSAS, for example, were consistent with substantial functional impairment, overall of 25. And the SHAPS indicated a substantial level of anhedonia, overall 7.8. Yes.
So you'll always see that every RCT starts with a chart flow, okay, to describe how exactly participants were randomized, and then the results will give you, a table to summarize the descriptive studies, so the description of the main variables of interest in each group. So this is almost always the case in every RCT, as you will see later. So now let's assess the outcome. Okay.
So we're going to start with this figure 2 of the paper, primary efficacy assessment of change from baseline in kids SR16 total score at week 12. And if you have another participant that would like to describe this figure for us. So you can see here both groups, placebo group in blue and the pramipexole group in red. And we have the time since randomization in terms of weeks. Like we said, the study took place until on 84 weeks. And we have the change from baseline of the primary outcome.
So as you can clearly see here, so there are different things that we see. So you will see the red and the blue line, and then you will see like an interval, just surrounding each of these lines. So the interval is the error interval. So we can understand that the difference was statistically significant if these intervals did not cross each other. So if they stayed really, so we can clearly see here that from week 4, maybe even earlier than week 4, there was a clear distinction, so a clear separation that's statistically significant between the placebo group and the pramipexole group. So maybe as early, okay, as after the second week. So the second week there was some overlapping, but then after the second week, you will see that there was no longer any overlap between the blue and the red. So, which means that the results clearly favored pramipexole over placebo throughout the period for any time point after 2 weeks, actually.
Yes, absolutely. And maybe another thing that we could take from this figure is how this difference has been largely maintained um, throughout the study.
And that's one of the big strengths of the study, as we'll discuss later on. So they kept assessing participants until week 48. Because most RCTs in psychiatry and in medicine in general usually stop at week 12 or maybe week 16 because it's costly and it's demanding and it's not easy to follow participants for a long period of time. But here they were able to do it for almost, let's say, 1 year. So we know that it's not just a transient effect, it's an effect that also, that's maintained over time.
Yes. Thank you. Okay, now moving on, at the 12-week primary endpoint, the mean decrease in kids' SR16 score from baseline was 6.4 in the pramipexole group compared with 2.4 in the placebo group. The difference in mean change was minus 3.91 with a 95% confidence interval between minus 5.37 and minus 2.45 and a p-value that is inferior to 0.001, indicating a significantly greater improvement with pramipexole, like we mentioned. Response rates also favored pramipexole. 44.1% of participants achieved response versus 16.4 in the placebo group. And here the response was defined as a reduction of more than 50% of baseline kids SR60. Remission rates followed the same pattern. A remission occurred in 72.9% of participants receiving pramipexole compared with 7.5 receiving placebo, with the relative risk, the relative risk was 3.94. Remission was defined as a KIT score that is inferior to 5. And at this time point also, we can notice that the therapeutic advantages of pramipexole was present across all secondary efficacy measurements that we mentioned earlier. And then at week 48, improvements in the pramipexole group were broadly maintained with a mean decrease from a baseline of minus 6.1. In contrast, placebo responses continued to increase after week 12, reaching minus 4 at week 48. The difference in mean change at week 48 was minus 2.02 with a confidence interval of 95%, and between minus 3.37 to 0.31 with a p-value of 0.021. Still favoring pramipexole, although the magnitude of separation between groups had reduced compared with the primary endpoint.
This is typical. You will see in most RCTs in psychiatry, especially in depression and even in like anxiety disorders. The magnitude of difference between placebo and like the active medication usually decreases with time. And why do you think this is the case? Bec- Well, because of the natural course of illness as well. So we all know depression waxes and wanes. So that we all often, even if it's a chronic illness, in this case for most patients, it's not like we don't have the same intensity of symptoms throughout the course of illness. So we know that it's a waxing and waning condition, and a depressive episode, even if left untreated, is likely to improve with time. And then, of course, people do relapse, but yeah, I mean, if you take, I mean, it's totally normal to see that the magnitude of improve of like effect decreases with time. It's very typical.
Another maybe reason that I thought of, and maybe we will discuss this later in discussion, is that the antidepressant treatment adjustment was allowed after the week 12. So maybe a question here would be, could be, could it be maybe another adjunctive treatment that could have been responsible for this decrease in the magnitude between the two groups?
Yeah, that's absolutely possible.
Now, moving on to adverse effects, there were 4 serious adverse events in the pramipexole group and 2 in the placebo group. None of these were judged to be related to the study medication. 2 participants taking pramipexole developed impulse control difficulties, but those were remitted when the dose of medication was lowered. The most common adverse effects that were reported in the pramipexole group were consistent actually with the known side effects of pramipexole, namely nausea, headache, dizziness, and sleep disturbance. Dropout of the study at any time point due to intolerance was significantly greater in the pramipexole group, so it was 20% overall, than in those receiving the placebo, which was 5%. And a functional unmasking, like we said, occurred in the study with 77 of participants in the placebo group guessing correctly that they were taking the placebo, and 71% in the pramipexole group provided the right answer.
Okay. Professor Cohen, I don't know if you have any comments about the results of the study, anything you wish to add?
No, it's thanks. It's a great presentation. I just wanted to say you can tell from my appearance I've been in this field for quite a long time, and it's the first clinical trial I've done that actually works. So I was pleased with the results, and it made a change to my usual practice.
I really loved the idea actually of the trial, and of course the methodology was also like very rigorous, but I really loved the idea because we always see RCTs about new molecules that are not on the market yet, or we see a lot of RCTs that are funded by the industry, but we don't see enough RCTs that take a drug that we already know and that's biologically plausible to work in a condition like depression. It's a medication that's already available, that can be purchased easily, that can be obtained, and we already have an idea about the safety of this medication because it's been used for a long time in Parkinson's disease, in restless leg syndrome, for example, for pramipexole, and then we try to use it in treatment-resistant depression. So I think it's a very good idea, and I don't think we have enough of these trials, to be honest.
Yes, I think that's a key point, Sunny, that for us working in psychiatry, the idea of drug repurposing, as you say, drugs that are known already that may be effective in psychiatric conditions, is very worthwhile pursuing, and it's a shortcut to treatment improvement.
And when someone like Professor Cohen says, "Yeah, this is the first RCT that has actually worked," you see that it's very difficult. Now, it's also
It
important,
is.
I think, for younger colleagues, including me, to understand how difficult it is to conduct a proper RCT, and it's even more difficult to have positive results for the
Yeah.
RCT. So it's much more common actually to have negative results than to have positive results.
Yes, and as you can learn a lot from a well-conducted negative trial. So I guess my message is it's worthwhile to keep persisting.
And the negative result is a result.
It is, indeed.
Yeah. Thank you. Thank you for sharing that. I would say that maybe one of the key points for me reading this paper is coming to the effect size of pramipexole, which was 0.87, which is compared to antipsychotics, atypical antipsychotics, for example, for it was between 0.27 and 0.43, and esketamine, the effect size is 0.36 in the literature. And I think this is quite important to know because this could significantly um, change the way we think about adjunctive treatments in treatment-resistant depression. I mean, the results are there, so maybe we would think twice before reaching to atypical antipsychotics, for example, as an adjunctive treatment in TRD.
Yes, that's right. We were impressed by the effect size. And we got the idea of conducting the trial from an open trial conducted by Jan Fawcett, which I think is worthwhile looking up in the American Journal of Psychiatry. And in this open case series, he treated people with very severe depression who'd failed lots of other treatments, and they did exceptionally well. So this makes us feel this probably is a large effect size if people can tolerate it. And I think you explained clearly there is a significantly high dropout rate because of the nausea mainly. So it'd be good to find ways of making this particular treatment more tolerable.
Yeah,
Absolutely.
absolutely. Like a peripheral D2 antagonist that doesn't cross the blood-brain
Yeah.
barrier or something like that.
Yes, I think our neurological colleagues are experienced with using pramipexole, and they have various strategies. I think actually one interesting one that some people are pursuing is adding a 5-HT3 receptor blocker, like on ondansetron. Something which makes it possible to take pramipexole and feel reasonably okay.
Absolutely.
Yeah. Okay, and also pramipexole was favorable for our secondary outcomes such as overall functioning, anhedonia, anxiety, clinician-reported depressive severity, and satisfaction with treatment. And as we said, this positive effect has been sustained um, until the 48-week mark. So yes, we did say that treatment discontinuation due to side effects in pramipexole group was larger than in the placebo group. The number needed to harm was 7, with the confidence interval of 59%, whereas the number needed to treat was 4. And these are also, I think, very important notions in
Mm.
RCT semi to consider. Yes.
Absolutely. So it's not just about the statistical significance. So we are
Mm.
always like, we first think of, okay, was the result statistically significant? It's also about the effect size. So the effect size is a very important thing. So just imagine a medication that can be, I mean, theoretically, statistically superior to placebo, but the magnitude of effect can sometimes be non-clinically significant. If, for example, I have a blood pressure medication that decreases blood pressure by 1 millimeter of mercury, is this really an antihypertensive medication? It's not. We know it's not clinically significant. The same applies to psychiatry. So here, the minimum significant decrease in the score was 3 points as per the literature. So here we know that this based on this, we know that okay, the average decrease was -4 or something. The effect of the medication itself, like when we also subtracted the placebo effect, which means that it was clinically significant. The effect size is another measure that says the same thing, and here we have the number needed to harm and number needed to treat. These are very important things everyone should understand. So when we say a number needed to treat or to harm, does anyone or can anyone explain this to us?
For number needed to treat, how I understood it is that it's the number of patients who need to be treated for one patient to benefit.
Absolutely. So for one patient to benefit from the actual pharmacological effect of the drug above and beyond the placebo effect. So if you have four patients, for example, and we give all of them, okay, a placebo, maybe, let's say, okay, two of them might respond to placebo and two would not respond. But if we give them pramipexole, maybe three do respond and one doesn't. So here, in this case, the number needed to treat is four. It's three minus two. It's one out of four. So one out of four patients or participants would actually benefit from the pharmacological effect of pramipexole in this case, which is actually a very good NNT in medicine in general. In psychiatry, it's rare to have an NNT of four, right, Professor Cohen?
That's right. I mean, I think probably anything under 10 is thought to be worthwhile. And obviously, other sorts of treatment, for example, statins, I think it's much less than that.
Yeah, it's 30. For statins, it's 30 or 30 something.
Yeah,
So
I'll
yeah.
go on taking it. Yeah.
So you see, and the number needed to harm is actually the same thing, but applied to side effects. So here, the number needed to harm was seven, which actually shows that there was a problem with tolerability to some extent. So seven out of every out of seven patients, there was one patient who did not tolerate the medication, probably because of nausea, as you said, right?
Yes, yes, that
Mostly. Impulse control was not that high. It was less, I mean, was not as high as expected, right?
yes, but oh, sorry.
Yeah, yeah.
Um, well, yes, it definitely was a concern because I think as Hen showed, it is high in Parkinson's disease, and actually we see it in psychiatry occasionally using aripiprazole, I think. Um, but for some reason, it wasn't high in this study, and that's either, I suppose, because people with depression are less likely to encounter this problem, or it may be because we excluded people with any evidence of impulse control disorders. So those factors are probably relevant.
Mhm. And also maybe because patients were, most of them were on SSRIs or something, that can sometimes decrease
Yeah,
some. That's yeah, also possible.
that's right. Mm.
Okay. Now, so we wanted to just have an open space for discussion before moving on to the strength and the limitation of this study and just hear from you after we expose the methods and the results. What would you think are the strengths and limitations? I think we have already mentioned a few, Dr. Renes. For
Yes,
example,
absolutely.
yeah.
So yeah, we can
Well,
show
I
the
don't know if
strengths and the limitations of the study
Mm.
and try to discuss them together. Sorry.
Okay.
Uh,
So starting with the study strengths, I think one thing that is obvious, this is a large multi-site randomized controlled trial, which of course increases generalizability and reduces site-specific bias because it's multi-site. The long follow-up period of 48 weeks, like Dr. Wernes said, is quite the highlight when we compare it with other RCTs in psychiatry. And it strengthens the conclusions about the durability of the treatment effect. There was also a comprehensive list of secondary outcomes such as functioning, anhedonia, anxiety. Um, sorry? So that provides kind of a broad assessment of the clinical benefit beyond symptom reduction. The involvement of people with lived experience, as we know, is now recommended in research. So that was it was worth pointing out. There was strong and randomization allocation concealment procedures. So we mentioned the non-deterministic minimization algorithm, the centralized online system, and the concealment procedures for researchers, assessors, for patients and statisticians. So those were masked outcome assessments, which limits measurement and expectancy bias and reinforces the internal validity of the study. And there was also a robust sensitivity analysis, but we didn't get into those details today. Now, maybe moving on to some study limitations. So there was no ethnicity data, which raises the question of maybe the representativeness of the results. And another point was how treatment-resistant depression was defined in this study, which was two trials of antidepressant treatments for at least 4 weeks at the minimum dose, or even less than 4 weeks if there's a tolerability issue. And this could maybe restrict, I would say maybe there's a lack of therapeutic response to a certain antidepressant at a minimum dose. That doesn't necessarily mean that the patient was resistant to that treatment at that current episode. So was something that I thought we could address, and maybe that's not maybe a true resistance, some would say. And another thing is there was an extensive exclusion criteria. So we did not get into details here, but there was a complete list of the exclusion criteria in the appendix, which could, I mean, it's understandable in an RCT, but it could maybe limit the real-world applicability of these results because, as we know, the treatment-resistant population is often complex with several comorbidities sometimes. So that is a point that I wanted to mention here. And another point is maybe the rapid dose escalation was responsible for the tolerability issues and the discontinuation rate of 20% in the Pramipexole group. So maybe if the escalation was a bit slower, maybe that could have influenced the incidence rate of the adverse effects. Yeah, so okay, should
I
I
think
continue?
also, okay, yeah, I think it's just worth noting that some of these limitations are actually common for most RCTs as well. So there's always a difference between the real world patients we have and the perfect candidates for RCTs for different reasons, like safety reasons, ethical reasons, and other reasons as well, like convenience sometimes as well. So yeah, so it's always difficult to completely extrapolate findings of any RCT, even the best RCT out there, on clinical practice because things are more complex in reality, right? I think Professor Cohen, do you want to add? Yeah.
Yeah, I think once again a superb summary. There was quite a lot of functional unblinding, so not surprisingly, as you indicated earlier, Sammy, people could guess if they were taking placebo or pramipexole, so that's an issue to be addressed. And I just mentioned there's been another study from Sweden by Jesper Lindahl, who's looked specifically at transdiagnostic anhedonia and has shown a good response to pramipexole there in a placebo-controlled trial. He used sustained release pramipexole, which looks to be better tolerated.
That's very good. Okay, I think honestly, I think everything, I mean, the main problem might have been the functional unmasking that
Yeah,
was contaminated by the outcome. So I think also the problem with the functional unmasking that I don't know why, but you assessed it very late, too late, at,
yeah,
after the outcome. So maybe it was contaminated by the outcome. So I think
yeah.
the assessment might have been, okay, it might have been better to assess it early on, right, Professor Cohen?
Yeah, I quite agree. When I looked at it, I realized we'd made a mistake because at the end, if you had felt much better, you might then have thought, well, I was on the drug. Whereas, as you said, the very early side effects, they're the ones to look at, and we should have judged it at that point. Six to
hmm
12 weeks.
Absolutely, yeah. But yeah, I think in general that's also I mean, usual. I mean, no RCT is perfect, and because it's so difficult to have, I mean, to control all these biases, it's
Yeah,
virtually impossible. So we try our best to control for as
yeah,
much as we can. I think also something we mentioned here on this slide, Dr. Hind, is important. The patient selection was not based on symptom dimensions linked to dopaminergic deficiency. So you took anyone with treatment-resistant depression, actually, that fulfilled the like, certain exclusion criteria. Sorry, and then you just added a pramipexole on top of their medication, and without actually seeing, I mean, selecting a subgroup that are maybe more likely to respond to and to pramipexole or to a dopaminergic agent. I think that this might make the study even stronger because I mean, if pramipexole works even without selecting this subgroup of patients, then maybe it might be better, at least theoretically, in a subgroup of patients who show clinical symptoms of dopaminergic deficiency. What do you
yeah,
think?
that's right. And we did look at the SHATs, which is the clinical measure of anhedonia. It didn't seem a good predictor, um,
hmm
but obviously there are other ways of measuring it. And I think you're absolutely right. As we try and move towards the era of precision psychiatry, being able to identify a group who respond specifically to an intervention is going to be very helpful.
Yes. So
Absolutely.
I put this point, I wouldn't necessarily call it a limitation, but this is an idea that I had when I was reading the paper. Like if it did so well with people with treatment-resistant depression, imagine how good it could be if we could maybe select a certain subgroup. So I wouldn't necessarily call it a study limitation, but I just wanted to include it so that maybe we could have the chance of discussing this with you.
Yeah, so maybe psychiatry will change to look at more important symptom domains. As I said, the Swedish paper looked at anhedonia across a variety of diagnostic groups, and maybe that's another way to advance our science.
Thank you.
Absolutely. Yeah. I think we're moving away from uh, categorical diagnosis, as you all know, in psychiatry. And I think I mean, research can be boosted if we focused more on transdiagnostic
Yeah,
symptom domains. Because our medications work on symptom domains rather than conditions or
absolutely.
disorders. Okay, so thank you everyone for being here with us today. Thank you very much, Professor Cohen. Thank you very much, Dr. Hind, as well for your excellent presentation. So just before you leave, I think we have just yeah two QR codes. One for your feedback. So it's very important to give us your feedback. This is the first edition. Unfortunately, I mean, we tend or we thrive to improve the format and the content. So your feedback is very important. And the second thing, I think also for early career psychiatrists, we want you to be here to present as well. So there will be a journal club every month, and we're happy to have you present to become the next journal club presenter as well. So if you are interested, please scan this QR code.
Yes, I want to. So again, thank Dr. Wenes for accepting me as a presenter, and I want to thank Professor Corinne. I have learned so much from this exercise, really, and from this paper, and I want to encourage other early career psychiatrists to take part in this initiative. Really, there are things that you simply learn by doing, I think, and for me, it was a very interesting mental exercise of kind of putting myself in the place of researchers and then going through it step by step from the design to the procedure to the results and the discussion. So it was very, very interesting. And
Okay.
with
Thank you,
that, yeah,
everyone. Thank you
I'm
very
very
much,
thankful.
everyone. And yeah, looking forward to seeing you in future editions of the Journal Club. Thank you again, Professor Cohen, for everything.
Oh,
It's a
thanks. It was an
pleasure to
honour
have
for
you
our
to us.
paper to be selected. It was an honour for our paper to be selected for your inaugural meeting. So thanks for inviting us.
Thank you very much. Thank you. Thank you. And congratulations for the paper. Thank you. Bye. Have a nice day, everyone. Bye.